And yes, we're about to go. So we are on there. We are on, and Adebayo, this is your core area, and Savan, this is your core area. I expect a lot of savants here, and we've gone in. And Nasir introduced Adebayo Funke for us, for her to get clanking and cracking.
Good morning, sir.
Thank you.
Yeah, I want to say good morning to our audience. Today gives me a very great pleasure to be here. The subject of the day, blood transfusion in pets, is something that is very dear to me, should be very dear to all veterinary practitioners, because it's a very crucial stage in the management of certain conditions that we all see in our various clinics, hospitals, and even on the field. Because a lot of people will look at blood transfusion and probably be thinking that it's just for pets, not for pets alone. It could be for equine, it could be for cattle, it could be for sheep and goat, depending on the price you place on that animal. And you want to use that last-ditch effort to make sure that that animal survives. So blood transfusion is something that is, well, I would say it's an enigma, so to say, because it's something most of us desire to do, but a lot of us cannot do, either by way of the fact that we don't have the knowledge, or the fact that we don't even have the equipment to make sure that this is done in our various hospitals and clinics, and then even the equipment and everything. But I'm not the lecturer for today, really, I am not. It's actually Dr. Olufunke Adebayo, who is a graduate of veterinary medicine from the Adebayo University, Zaria. She currently works at the Veterinary Teaching Hospital of the College of Veterinary Medicine, Federal University of Agriculture, Abeokuta. She's passionate about companion animals, focusing on internal medicine, canine babesiosis, blood transfusion, and ultrasonography. She's a fellow of the College of Veterinary Surgeons, Nigeria, and has PhD in companion animal medicine. She's married to a heartthrob, a fellow veterinarian, and a professor of veterinary anatomy. So it's a veterinary family. I've listened to Funke several times, and I think it's always a delight listening to Funke. So Funke, I welcome you to the stage now. And I'm told that we'll have this lecture, and after this lecture, there's going to be question and answers. And I'm going to encourage those who are already on the call at the moment right now to listen very well and make sure that at every point in time that you are confused, please note your questions. We are going to have a very robust discussion on this subject today. So, Dr. Adebayo, I welcome you to the stage.
Okay, thank you so much, sir. I'm so grateful and delighted to be here. Please, I don't know if I'm audible enough.
Not very well.
Okay.
Looks as if you are speaking from a distance, so you can improve it. Yeah.
Oh, okay. All right. I'll just increase my volume. Is this better?
Yes, I think so. Yeah.
Okay. All right. Thank you so much. Please, can we see my slides?
Yes, very well.
Okay, so I really want to appreciate each and everyone for being here today. I'm so grateful for the opportunity from Bluebird TV, and for this time, I do not take it for granted the opportunity to be here today. So we are going to be talking about blood transfusion in animals, in pets generally, and so we'll kickstart from there. Now, one way or the other, I know that some of us might have, maybe as humans, heard, of course, or gone through blood transfusion. So in this particular case, we are trying to look at in animals. Okay, so basically, blood transfusion is transferring blood or blood products into the blood system or circulatory system of another animal. And So many things have been transfused. We have a whole blood, and we could transmit components of the blood. So, and I love one particular article that I read and said, blood cannot be manufactured in the lab. And so as much as, or as long as we cannot manufacture blood in the lab, then it behooves us to see how we can help our animal patients to see how they can get blood as and when needed. So I had the opportunity of visiting Bristol some years back, and this was one of the theaters that we used for surgery. And you can see how well lit and well prepared this surgical room is. So alas, what we're waiting for now is to carry out the surgical operation, but we need blood. Okay, so there are some surgical procedures that you cannot go into the theater without having blood transfusion done. Okay, so we'll take it from there. So I just said the theater is set. Okay, so why transfuse blood? Why do we need to transfuse blood? Why? Number one reason is because of its components. What does it give us? We cannot transmit something that does not benefit us anything. So for us to transmit blood is because certain things are therein in the blood that is beneficial, humans and animals alike. Okay, so one of the things that are beneficial about transfusion or transfusing blood is the red blood cells. The red blood cells, the blood volume of red blood cells is about 45% and is generated from bone marrow. Platelets too, one of the reasons why we need this blood transfusion done. We need the platelets, and we see that the importance of platelets is that it controls bleeding and is very essential for wound healing. Plasma is also one of the components of blood, made up of water, proteins, and so many other things. Then white blood cells. These are the fighter cells. So there are some of these components that are so essential to the body, and that is why we need blood to transfuse to needing animals. Okay, so which of these pets is in need? How do I know that this particular animal will need blood transfusion? And this will take me to the indications. Why do we need blood transfusion? Why do we need for this particular patient? Number one, basically, we are transfusing blood because of anemic crisis, because of shortage of blood. We know that when there's shortage of blood, when there's shortage of blood in the system, then there is shortage of oxygen. And when there's shortage of oxygen in the system, we know that that particular system will eventually die because of the lack of oxygen. Oxygen is life. So, and this life, this blood that transfused, oxygen is a major part of it. So when an animal patient is coming into the hospital with anemia, that animal is having shortage of oxygen in his blood because of the anemic crisis. So the indication generally for blood transfusion is anemia. Anemia or shortage of blood could occur because of hemorrhage, the animal is bleeding, or there is a blood loss, or there is a coagulopathy, a problem with the coagulation system, or there is hypoproteinemia. We'll see this as we go on. Okay, so what are the causes of anemia? And that's what I try to outline here. You could have blood loss. Maybe an animal had a road traffic accident, an RTA, and so an accident, and because of the trauma, you have a lot of blood loss, or you have diseases that prevent blood clotting. An example of this is ehrlichiosis. You can have tumors. There are certain tumors that they cause a whole lot of blood loss. Another reason why we know that, oh, this particular animal needs blood transfusion is when there's hemolysis. When we're talking about hemolysis, we're looking at the red blood cell breakdown. Something somewhere is breaking the red blood cells, maybe parasites. Sometimes you have immune-mediated hemolytic anemia. And sometimes you have chemicals and toxins. And the third situation whereby we need blood transfusion is when there's a decrease in the RBC production. That shows that there's a problem with the bone marrow, or maybe there's a bone marrow suppression, either because of a kidney or a liver or an autoimmune disease. So these are more of the reasons why we do blood transfusion and how we know that this particular animal will need blood transfusion. So what do we need to get done? What do we need to do, with blood transfusion? What are the things that we need for blood transfusion? I started earlier by saying that the components of the blood are so essential, the white blood cells, the red blood cells, but it is not only whole blood that is being transfused. Recently, there has been fractionated blood components. So you don't have to transfuse the whole blood. You can either transfuse the packed red blood cells, the plasma, or some precipitates or platelet products. So it's not compulsory that you transmit or transfuse the whole blood. You can transmit the particular need of that patient. If your facilities are adequate enough for separation and for preservation, I must emphasize this. In our own practice in FUNAB, we most oftentimes do whole blood because that is what is quickly available and accessible. We do not have the facilities to fractionate blood yet. I'm hoping we'll get to that level. Not to talk about the light issue. Electricity is very important for having a blood bank. So presently we do not have a blood bank. What we do is that for time when the animal is in need, we have certain dogs that we have spoken to clients about, and they are more than willing at any time because we have typed their blood. We'll soon get to blood typing, and we know the dogs are always in good shape. Okay, so I put this caption to say dogs are really interested. You mean we can be lifesavers? So dogs can be donors and they can be recipients for those that need the blood transfusion. So I could just go on with that. Okay, so the first thing we want to look at in blood transfusion is blood typing. We've been able to come up with the fact that, okay, to identify the patient that needs particular transfusion. So what do we do as per blood typing? Well, life is more easier now because there are blood typing kits. So we don't have to crack our brain and to see how we're going to do some of these things. There are very wonderful kits that are available that help in blood typing. So this is one of the kits, and it's so easy. It's an easy procedure. They come with buffer, and all you need is just 2 or 3 drops of blood. So they come with buffer, and with this buffer, you do a mix, and then you follow the particular procedure, and then
I think Dr. Adebayo is frozen. Maybe a network.
Nasir, please get hold of her, please.
Yeah, I'm trying to.
Get hold of her, Benin.
I'm trying to.
If you are getting hold of her on the phone, you mute. Oh?
Yeah.
At times we have these glitches once in a while, but I think we'll get to the end. Yeah. So please,
she's trying to come back. She's trying to come back.
Yeah, we are okay. Good. Yeah. Then, if anything, you have to top up, Nasir, so that we bridge the lacuna.
Okay, no problem. Yes, like before our lecturer comes back, I would like to say that where she is at the moment about cross-matching and typing is actually the main problem that practitioners like me and you would have because of the cost of the equipment, that to be used for this type of cross-matching and all that. And you know that there is this popular belief that, oh, when you want to do the very first transfusion, you don't have any problem. You can use any blood and anything, especially in dogs and cats. But then by the time you want to do your the second transfusion, then you should expect some reactions and all that. So a lot of us are not really very, very on ground when it comes to the issue of a repeated transfusion, so to say. Because there's a propensity of you harming the patient that you are trying to help because you don't have the cross-matching thing, to match whether this blood cell, you can use it for the dog and for the second time. So that presents a very big problem, a very, very big problem. And that was why when I said it's something that we all desire to do, but we also think that we cannot do, because of the. And another thing is about, I'm sure because I've seen her paper and I know she's still coming, but just to paraphrase, another thing is the cost of getting this transfusion done. It's except a premium is placed on the patients, on the recipients.
Yeah, she's back. But unmute yourself.
Fantastic.
Unmute yourself.
Okay.
No, continue talking until she rolls in. Yeah. Okay, you can continue, Funke. Thank you. Don't worry for the glitches. We covered you.
Okay, thank you so much. Okay, sorry about that. The network is really acting up. Okay. All right. So please, can we hear me now?
Yes, we're here.
Okay, so I'll just continue from there. So I said the most important antigenic blood type that is of importance, crucially, is DA1. So this basically the test that we have available. Most test kits will test DA1. So once the dog is DA1, you are able to know whether it's DA1 positive or DA1 negative. Basically, that's the major one we need to see. So let me go to the next slide. Okay. All right. So knowing now that we need, okay, DA1, so let's assume we have done the test and now we know that, okay, our donor is DA1 positive or donor is DA1 negative. What else do we do? The next thing is go to blood donation. So for the blood donation, I want to put a caution here that blood transfusion is not the first line. So it's not that the animal is anemic and the next thing we start looking for is to transfuse. There are certain things we should do before going into blood transfusion. Number one, you want to try the option of crystalloids. You want to give IV fluids. These are very essential. Lactated ringers as Hartmann's. You want to do dextrosaline or normal saline. We can start with this, but we have to check what exactly the packed cell volume of this patient is. For us here at FUNAM, if we have a pet coming in with a packed cell volume of less than 10%, we want to be careful about crystalloids. We don't want to give crystalloids because that will further complicate the anemia. Okay, but if we still have a patient, say 12%, 15%, we can do slow infusion of either lactated or dextrosaline, as the case may be. Okay, so that's what we normally do. And then if you don't get any result, or if you can't go do the crystalloids, we can do colloids. For the colloids, you can, we have done, we have used isoplasma. These are plasma expanders. They would help, with the particular situation where the patient really is in an anemic crisis. So where crystalloids don't help, where colloids don't help, then we now begin to think of blood transfusion. Okay, so number one, how do I go to this blood transfusion? Number one, you need to know that I call this blood group dynamics. Number one thing we should know that who is the donor? The donor in dogs, DEA1, has to be a DEA negative. So we can say that a DEA1 negative are universal donors. And then so you can then begin to talk about who is the recipient now and how do you go about, transfusing blood. So You want to ensure that a DEA 1.1 or 1.2 negative is your donor, and then you can give a DEA 1 positive to a DEA 1 positive recipient. That means that you can only give DEA 1 positive to DEA 1 positive. Okay, so but universal donors are DEA 1 negative. So let's assume you do not know the blood type or group of your recipients. You can at least know the blood type of the donor. The donor must be a DEA negative, so that when a DEA 1 negative gives to a DEA 1 positive, we are fine. When DEA 1 positive gives to a DEA 1 positive, we are still fine. Now, that's a bit different for cats, because cats do not have DEA. The DEA is dog erythrocyte antigen. So cats have their own blood types, very similar to humans. They have their A, B, and AB. Now, peculiar to cats, the donors, the blood types are the donors of themselves for cats, which means a type A is the donor for a type A. So a type A will donate to a type A recipient. A type A donor of a cat will donate to a type A recipient. A type B donor cat will donate or transfuse to a type B donor recipient. That's how it goes. AB is very scarce in cats, but that is the third type of blood group they have. I must say at this point that in dogs, they have over 13 types of blood types. But like I said, the most antigenically relevant or important is DEA1 in dogs. It's crucial to do cross-matching. There's something called cross-matching. Cross-matching is basically testing for antibodies. Antibodies in the recipient and antibodies in the donor against their erythrocytes. That's basically what cross-matching is. And there are minor or major cross-matching. I want to really appreciate Savan, because at the last year's Savan meeting, conference, we actually did blood transfusion, and then we did minor and the major cross-matching, courtesy of Dr. Abiade and Dr. Latunji. They were able to provide us with these kits, and we saw hands-on how to do minor and major cross-matching in dogs. Okay, so that's about the cross-matching. So what are the requirements during blood transfusion? We have been able to say the donor must be DEA1 negative. Apart from that, they must be healthy animals and adults between age 2 and 8. For some cats, you can actually get a donor as early as age 1, but most times we want to do between age 2 and 8 years, and they must weigh more than 30 kg. That's for dogs, and cats about 3.5 kg. We must ensure that these dogs are healthy, and the packed cell volume of the donor should be above 35%, and they must be fully vaccinated. These dogs must be screened for various hemoparasites as much as possible that we can do in our lab. Of course, you know, we don't have access to do all this screening, but at least the major things we can do in the lab, we need to do: screen for tick-borne diseases, which are prevalent here.
Yeah, frozen again. And Nasir, please, can't expatiate him before she comes.
So she's frozen again, but I think what she's just trying to do is just a requirement for blood transfusion that she was talking about the issue of having LV donor. You can see who must be between 2 to 8 years, with a minimum weight of about 30 kg and 3.5 kg for cats, which is very, very important. And then they must be very healthy. You have to do a lot of testing. There must not be any parasitic infection. There mustn't be any viral infection like parvo or the rest. So those are the kind of things and then the animal must be well nourished, you know. So it must be a perfect donor. It's not just going to be any dog I just want to bring from anywhere and say, okay, this is a donor and all that. And then the requirement of having a PCV of at least 35%. For me, I don't even take 35%. I want to go as high as 40. if it's possible. When it's not polycythemic anyway, when some of these dogs are dehydrated and then they have PCV high, not that, in a healthy animal. These participants should just mute themselves. They are not speaking. Please mute yourself.
Yeah, mute yourself. Okwada, mute yourself.
So that we can all enjoy this. I don't know which Dr. Charles Amako, please mute yourself. Charles Amako, mute yourself, please.
Host can mute everybody.
Well, I think they say the host can mute everybody. Yeah, they always take permission before they can be. Dr. Amako Charles.
I muted him. I muted him.
Muted him. Fantastic.
Continue.
Okay, fantastic. So we're talking about the issue of PCV requirement for the donor dog. And for me, I said I'm not even starting. I'm not stopping at 35. I'll be like talking about something like 40 or 45. And then if we can all get these dogs, the greyhounds, they are reputed to have very high PCVs, their blood, almost 40, 45. But I'm sure that the operationalization of that suggestion may not be something that we are all like very comfortable at doing, because I don't know the last time I saw a greyhound. But there are so many other dogs that you can actually just get random donors. It is important that Amako is back again. It is important that
continue.
You should have one or two dogs that are primarily kept with you for blood donation, so to say. You are keeping them because it can be relevant when they're there. Because at any point in time, a situation can arise that you have to use blood. And like our lecturer says, until she comes back, these are dogs that you have to keep very healthy. These are dogs that you have already determined what group they have. Like she said, we have the universal donor, which of course I'll probably advise that's what you should keep. The DA1 negative can donate to any dog, can donate to a DA1 positive, So I'll probably advocate that, and I'm going to seek validation from her when she comes back one way or the other. So I think it's something that we have to do. There are challenges. Okay, I think she's coming back. There are challenges, because here we collect the blood and we use it. There is no opportunity for storing because of the challenges of power. And then, like she also said, you cannot fractionate because sometimes you don't need whole blood and you need components of blood, like the red cells or maybe washed red cells. You want plasma, you want the platelets and all that. You cannot do that in our climb here, but it's something that we should aspire to do. Maybe by the time the VC and the new council comes on board, they're able to establish specialty practices across the zones where we can do some tertiary consultation, and all that. So it's a whole lot of problems within the system now that most of the potentials of what our people, of what we can do in our various clinics and hospitals and on the field cannot even be realized because of lack of equipment and the wherewithal. I'm also saying something that I'm afraid of. For me, most of the people that we have asked to come and do blood transfusion here for their pets, they have always rejected because of the cost involved in the whole process, And sometimes, except of course, you are like, yeah, let me be an animal welfare enthusiast, because sometimes the question arises, you have the ability to help this particular patient.
Yeah, I think Funke is back.
Yes.
Yes. I'm back.
Funke, you're a lecturer, you're not a student.
We're only talking to
So
cover the gaps.
this network is
Okay.
so amazing. But I'll just continue. Thank
Okay.
you so much, sir, for holding
Continue.
up.
Fantastic. Okay.
Okay, sir. Okay, so I think we were at where now? Okay, so we were at requirements. Okay, so I've had to change to my phone. I hoping that will be so. That's why I'm not with I had to just reduce.
Are you using your phone now?
Yeah, so I'm using the phone now, so I'm taking off the video, so I'll just do audio. I hope that's fine.
Okay.
Yeah, that's fine for a while. That's fine.
All right. Okay. So so basically, so we need them to be fully vaccinated, and then that's it about that slide. Okay. So for blood collection, there's for the blood.
Please expand your screen.
Okay.
If possible. The font.
All right. Okay. Let me do the other way. Okay. All right. Okay, is this better?
Oh, beautiful.
All right, thank you so much. Okay, so for blood collection, we need blood bags. Okay, so we need blood bags, and these blood bags, their anticoagulant is citrate phosphate dextrose adenine. Okay, one, and that's the anticoagulant that blood bags come with. And these blood bags they are in 450 mils, and the anticoagulant is about 63 mils. So that's we're going to see a picture of it pretty soon. And then so for the whole blood, we see certain things that benefits that they are able to give us, provides clotting factors, limited platelets, and red blood cells. These are just additional information. Then we have to collect the blood from the donor and use within 2 hours. Some say max 4 hours, but 2 hours is pretty important. Once we collect, so when we collect blood, we transfuse immediately to a needing patient, not that we store it, especially because of light situation in Nigeria. Then we at the dose of 10 to 20 ml per kg is what we use for calculation of the amount of blood to withdraw from your donor. So from the donor, assuming I have a donor that is 30 kg, so if I want to do 10 ml per kg, so that means I should take 30 times 10, 300 mils from this patient. You know, I said the blood bags come with 400 mils. It's a 400 ml bag. So by the time blood and, you know, the anticoagulant mixture, so that's why most people call it a 500 ml bag. But basically, it's actually 450 ml bag. So I'm okay if I do about 300 mils from my 30 kg donor, collect that and transfuse that to my needing patient. Okay, so let's go to the next slide. So this is the calculation for blood transfusion. So the volume to be transfused, so you take the weight and then times 90, which is a constant, and then the donor PCV, the recipient's PCV over the donor PCV. This will actually give you almost what 10 to 20 ml per kg will give you. So this is just breaking down the calculation into smaller bits. Okay, so these are red blood cells and plasma. So on the left, you have the red blood cell, and on the right, on my right, you have the plasma. Okay, so blood transfusion, what we knew was that the first transfusion is free of immunologic complications without blood tapping and cross-matching. But recently, it's been known that even the first transfusion, sensitization comes in. The body system is already sensitized, and then there's development of antibodies over about 4 days. And these could actually lead to delayed hemolytic transfusion reactions. We are going to go to transfusion reactions in a bit. So, and then we used to know that DEA1 negative is actually a universal donor. Well, not as universal as that. It has to do with the particular case. Look at what we said about cats. There's no universal donor in cats. A gives to A, B gives to B. So in certain situations like that, it happens. So then we used to know that their RBC infusions could take place using infusion pumps. There are some times that now you just transfuse based on gravity, and you may not have to use infusion pumps. Okay, so blood collection and administration. To collect the blood from the donor, you have to do a jugular venipuncture. There are some times that we don't get to do jugular, we can actually do cephalic. But jugular under gravity will ensure that the blood flows better and faster, so that because you do not want the blood clotting, even in the blood bag. So the jugular venipuncture, so that means that you must be well accustomed with jugular in cats and in dogs. Okay, and then so the patient can be sitting on lateral or on sternal recumbency. Okay, so like I said earlier on, that you can either collect blood, under gravity or with vacuum pump. Sometimes we may need to sedate, especially cats. And then, but most of the ones I've not done in cats actually. It's just been dogs. I'm really hoping that I will do cats very soon. But in dogs, the ones I've done so far, we did not need to. We proper restraint, we were fine. But of course, there are some dogs that you don't dare, do that. So you can of course sedate before blood collection. And then you collect and use within 2 hours. I said that already. And then for cats, you give 10 to 15. Earlier, I said 10 to 20. I love to do the lower limit. I don't want to do 20. So that's why safely here, again, I put you could do safely 10 to 15 ml per kg for cats, and then for dogs. So we must make sure that we do TPR, that's the temperature, pulse, and respiratory rates. They must be taken before, during, and after the transfusion. If I could enlarge a bit, you see that's the first one up there is the blood infusion set, and the second one down there is the blood bag. Okay, so I didn't want to be advertising products, so that's why I had to cover it a bit. Okay, so to go to the next slide, blood transfusion dynamics. Okay, so we calculate 2 ml per, so a 2 ml per kg will raise the PCV for about 1%. So times 10 of that will raise it to about 10%. So the initial flow, so now when you have collected the blood from the donor, the initial flow that you must give to the recipient now, it should be less than 5 ml per kg per hour. So a lot of calculation going into that. At least less than 5 ml per kg per hour that's what you should do in the first 15 minutes. Now you're observing, checking, is there any reaction? Is there anything strange about this dog or this cat? Then we should handle transfusion reactions accordingly. There are different transfusion reactions. There are so many, but we can't exhaust them today, but we just touch on one or two. And then rightly calculate your anticoagulant. And this is very important. And we did this at the last year's Savant conference, practically, because you have 63 ml of anticoagulant in the blood bag, and then you have the capacity of the blood bag is 450 ml. So assuming that I'm supposed to take 300 ml from my donor, you realize that you are going to be having more than enough citrate or anticoagulant in the blood bag. So we have arrived, my boss and I call him my boss, Dr. Mobawale and I have, achieved this calculation by saying that you should then give 1 ml of the anticoagulant to 7 ml of blood. That's the ratio 1 to 7. So 1 of the anticoagulant to 7 of the blood. So that if I'm going to give a 300 ml, I don't know if someone can calculate immediately now. So if I'm going to give 300 ml, so, so 450 is to 63 ml. Now, 350 ml of blood is to how many ml of anticoagulant? So someone can help us with that calculation. So that means that by the time you get your blood bag, you have to remove some anticoagulant, because if this is not removed, this can lead to transfusion reaction, which is citrate poisoning, and that could get the dog into more trouble than the blood we're trying to put into the patient. Okay, so those are one of the dynamics. So transfusion reactions, there are so many.
In fact, we have a whole list, but because of time, someone has given us 49 meals, voila. So that means that you would get rid of 63 minus 49 meals. So you can help me with that. So 63 minus 49 meals will be the number of meals you will remove from that blood bag, and then you are safe to transfuse, to put in 300 mils of blood in that blood bag. Thank you so much, Doc. Okay, so transfusion reactions, there are so many. Number one, you have hemolytic transfusion reaction, where you see that during transfusion that the dog has or the cat has fever, you notice tachycardia. That's why we say monitor the TPR. Then there's dyspnea. Sometimes the patient collapses or is cyanotic. And so what do you do immediately? Stop transfusing. Stop transfusing, come in with your crystalloids, Hartmann solution, dextrosaline or normal saline. And then you can have non-hemolytic febrile reactions. Basically, you just notice that there's fever, uncontrolled fever. So you also want to make sure that there's someone monitoring the patient, especially temperature, pulse, and respiratory rate, and then the disposition of the patient. You're looking at the eyes, you're looking at the tongue, you're looking at the body, because the next one is going to urticaria. There's some animals that when you start transfusing, you start noticing them having bumps on them, wheals, on their body, and like small pimples on them. You want to quickly ensure that you stop your infusion in case of urticaria reactions, or you reduce the flow, and then you give diphenhydramine or you give chlorpheniramine, usual Piriton, at the appropriate dose. And then sometimes you could see a case of sepsis where the animal just goes into shock following fever. You'd stop the infusion immediately and come in with antibiotics, and then you do a shock therapy. Some people, for shock therapy, they give large boluses of IV fluids, and then you come in with dexamethasone or as the occasion says, or hydrocortisone. And then when there's circulatory overload, there's sometimes that maybe due to inadequate or incorrect calculation, much more than needed is given to the recipient. So that's an overload. And before you know it, the dog or the cat or the animal starts coughing and is dyspneic. You should stop infusing immediately and then give diuretics. And then you give, if you have, if it's available, cardiorespiratory support. And there are other transfusion reactions. I've mentioned this earlier on. You can have citrate toxicity when you have an overload of the anticoagulant in your blood volume, and then it causes a whole lot of harm than good. And then you have hemolysis coming in. So that's that about reactions. Then contraindications. There are certain contraindications with regards to blood infusions. I've mentioned this actually. So the major one I'll talk about in this slide is pregnancy. We don't collect blood from a pregnant dog. We don't do that. From pregnant cats, from pregnant animal, they are not suitable donors. So you don't go there. And then I also mentioned here that for DA1 positive donor to DA1 negative recipient creates an antibody induction. So I've mentioned earlier that the universal donor for a dog is DA1 negative. And so we need to ensure that. Then these particular pictures were actually during transfusion. That's with the A1. Okay, let me. The other picture with the male there, it's at the VTH for NAB where we're transfusing blood. You'll see that there's dextrosaline. That's for the, that was for the donor, and the recipient is the one on the table there receiving the blood. And then the one on my right, which is B, was during the Savant conference last year where we were doing blood transfusion in that particular dog. So I want to say thank you so much. Sorry about the network issues, and I'll be glad to, together with my guys here, to answer some of your questions. Thank you so much. Thank you.
Thank you, Dr. Adebayo, for that inspiring lecture. And I think it must have agitated a lot of us in our minds now as to what questions we should ask. Right now, I have questions on the chat box, but before I go to the question on the chat box, I'm sure there are lots of things that you wanted to say that perhaps because of the network issue and everything, you were not able to say them. So I'm going to ask you some 3 questions now. Please let me take them down because this is the beauty of the lecture itself. Can you hear me, Dr.?
Yes, sir. Yes, sir.
Fantastic. I want to go to transfusion reactions and complications first.
Okay.
Because, I want us to do that. Then we'll go back to the possibility of carrying out blood donation, transfusion in our various hospitals and clinics, because I see a lot of private practitioners and even those who are on the field who are already asking questions about how you can transfuse blood to cattle and horses and all that. So you mentioned it, but for emphasis, I just wanted to also recast. What are the signs of an acute hemolytic transfusion reaction in animals? You have said it. There was a particular slide that actually addressed that. Maybe you bring it back. Then, how do you manage a transfusion reaction in an animal? You have said it, but you have to recast. Then, what are the long-term complications of blood transfusion in animals, if there are any? So, I want you to take those 3 questions before we go to other ones. Thank you.
Okay, so we have signs of acute hemolytic reaction in animals. Generally, you see that there is an hemolytic crisis. You see that it happens in some dogs that we have even experienced here at FUNAB. We notice that some dogs, they appear to do fine, after the blood transfusion, but some 2-3 days, and this is what we call a delayed, transfusion reaction. They came back with a whole lot of problem. 1 or 2 actually died, because they had some organ issues. So number 1, we want to look at the state of the organ, or the state of the general state of that animal. Animals that have organ failures actually do not do too well with blood transfusion and blood transfusion reactions. But what we can do is just to see how we can make do with the little resources we have, that we have opportunity to do. So when a dog is coming in with acute hemolytic reaction, we notice that even with the blood that has been transfused, because what we do is that we take the packed cell volume before transfusion. Then that's number 1. Then we take 48 hours after transfusion to monitor the PCV, and then we can do 72 hours after transfusion. So we notice that some dogs that we actually transfused 48 hours, did not appreciably have an increase in the PCV, rather it depreciated. And so such dogs are candidates of an acute hemolytic crisis, that there's something lies in the blood, either parasites or something. It is not the recipient that we screen, it is the donor that we screen. So there are some times that even the recipient, that's why I said that, look, blood transfusion is actually not the first line. We have to identify what caused this anemia in the first place. Because for an immune-mediated hemolytic anemia, that means that the body is fighting itself. So what is causing the immunosuppression and making the dog's or cat's blood system fight itself? Could it be a tumor? Could it be a bone marrow suppression? Could it be a bone marrow tumor? So these are some things that we love to screen, even in the recipient. We love to know, okay, if this recipient has some blood parasites. So in addition to the blood transfusion, we want to do antibiotics that will take care of the blood parasite. If this dog, the recipient, is having, let's say, sepsis, we want to make sure we come with antibiotics to take care of the bacterial overload in the patient.
Adebayo, Dr. Adebayo,
Yes,
I hope
yes,
you
sir.
won't mind me cutting you some, because
No,
along the line,
I don't mind, sir. Yes, sir.
you mentioned the use of antibiotics now.
Yes, sir.
Are we just allowed to use antibiotics like that, or without doing some how do I call it, some because in the era of this antimicrobial resistance,
Yes.
would you just want to like, okay, because this dog is having an issue, an infection, let me just come in with antibiotics. How do you determine the kind of antibiotics that you want to use at this stage?
Yeah, thank you very much, sir. So for those that we have a strong diagnosis, let me say, for example, tick fever, I am good with Oxytet. So that's just the basic, but there are some, like in case of sepsis, that we want to be very sure which antibiotic to come in with. Then we need to do a microbial culture and sensitivity. We do not want to treat blindly. So for such dogs that have sepsis, we've seen some dogs that even in the septic condition, they came with otitis. So you see a whole lot of foul-smelling pus from the ears. So in that case, you can do an ear swab, take it for microbial culture and sensitivity. With that, you'll be able to know the right antibiotic to use. And additionally, you could do a blood culture.
The time is lingering. That will come back in about 72 hours.
Yes, but the thing is that we can always start from the basics. You can never go wrong if you start with lower antibiotics. For example, you can start with the simple penicillin streptomycin. So we shouldn't look at the patient and not do anything, but we could actually start with some lower antibiotics. So penicillin streptomycin is fine. We also do sometimes amoxicillin. And then, so at least before the blood culture or the MCS comes in, we have started something. And then we keep monitoring, especially the TPR and other parameters.
Yeah, that's just one of them. I said, how do you manage? Okay, you have said it. How do you manage?
Yeah, so how we manage transfusion reactions? There are so many reactions.
Yes, go ahead.
Yeah, there are so many transfusion reactions that if I could put it safely, since we're all vets, you could treat symptomatically. And like now, if I'm having, the animal is having wheals or is having urticaria, symptomatic treatment will tell me to come in with antihistamine, so I can use anhydramine or chlorpheniramine. That will help with the urticaria situation. If I'm having a pet in shock, I could come in with shock therapy. So majorly for the transfusion reactions, we treat symptomatically. If you don't see the symptoms, you don't need to treat that. It is based on the transfusion reaction symptoms that you see. That is what you should do. In case of citrate toxicity, when you begin to see signs of circulatory overload, I said you stop infusing in circulatory overload or in citrate toxicity. If you notice that, I didn't do a good calculation, I gave more, there's more citrate in the blood, we withdraw the transfusion immediately and then start giving IV fluids. Crystalloids will help flush the system, and then you want to do diuretics. So basically for the transfusion reactions, I'll say treat symptomatically. If you go into trouble or if you run into how do I go about this, we could always visit a nearby colleague or visit the books. Now, for long-term complications, I made mention of the fact that there are some dogs or cats that have delayed reactions. So those long-term complications will take us to monitoring our patient even after discharge, because we may not be able to keep the dog after the blood transfusion. So we keep monitoring phone calls, telling them to come for their appointment so that we can monitor the parameters. It would not be out of place to do a liver function or a kidney function test if the patient or if the client is willing to go that far for the patient. So there are so many things that we can do, on the long term to monitor the long-term complications.
Yeah, Nasir, are you looking at the chat box? There are a catalog of questions there. And then Funke and Nasir, check the chat box and I'll start addressing them one by after the other.
All right, on the chat box. Okay, so someone said blood donation and blood banks in Nigeria, in animals, discuss. What happens in large animals with blood transfusion? Yes, this is a major area. Honestly, blood transfusion is a major area that we need to look at in animals in Nigeria. Like I said, if we cannot deal with blood banks now by the reason of electricity, thankfully we have solar But I don't know how far this solar system can take us, but it's a good place to start. I am really thinking, together with some of my colleagues here, thinking of how we can have a solar system to see if we can even start blood banking. We have not started. We are still putting pen on paper. But for animals in the field, you can do a direct blood transfusion. The first transfusion is still okay. Is when the animal will need to take a second transfusion, that is when we need to do blood typing. In fact, in large animal is a whole lot of world there entirely. So the basic thing, if you're on the field, know the packed cell volume of the donor, your prospective donor, and the packed cell volume of the recipient.
No,
If
I
your
think
donor,
Funke, we will bring the large animal physicians to come and discuss that. This is
to come
your
and discuss that.
stereotyped to
Okay.
pet. Oh,
Okay,
limit
all
yourself
right.
to pets.
Okay, okay. Thank you very much, sir.
Can I ask this question? Because you're already talking about it, but that was what I wanted to ask the other time. Because we have a lot of hospital representatives here, clinics and all that, who would desire to have something like this in their practices and all that. So what are those basic requirements for establishing to select your donor? You know, for example, while you were off, we're talking about keeping a dog also in the clinic and all that. So what are those basic requirements that you must have? Those kind of pathways that you have to work before you can say, yes, I can do an emergency blood transfusion in my clinic. Because the essence of the discussion is, if we're not able to apply it tomorrow or Monday or in another week, what is the essence of coming to listen to this lecture? So for me, what are those basic things that a fledgling vet can do, you know, in his own clinic?
Okay. Yes. Thank you very much, sir. It's very important. Now, coming practically now, okay, I actually mentioned it while I was discussing, for us to have it practically done. Number one, if as much as possible, you can have a dog, a clinic dog, that you know that this particular one is available for me anytime. It's in good shape, vaccination up to date, those requirements that I placed there, good to go. So the first thing is to have a donor. Now, you can go further to test your donor. These kits are actually imported. I know that I think some clinics in Lagos, I have an access to it. So it depending on who needs what, and also Bluebird TV can actually do a collaboration with us to see how we can get some of these things. So the next thing, if you have been able to get a donor dog, next thing you want to do typing of that your donor dog, that you know that 247 anytime this dog is available. Because when you have typed your dog and you know that that dog is a DEA1 negative dog, it's a universal donor. It can donate blood anytime T. So all you need to do is just to put that dog continuously in top shape and to be available. Of course, you don't want to keep bleeding this dog every day in the name of blood transfusion. The best you can do for that kind of a dog is to take blood at least once in 2 months. If you are taking blood per time, you're going to wear out the dog. I advise once in 2 months, it's fine. Maybe if you have an emergency, once in a month. But you have to make sure that the dog is always on iron supplements or hematinics to make sure it's already, is always in good shape. So now that's number 2 now. Number 3, you want to then make available, if you can, your cross-matching kits. This will just let you know if there is anything or any antibodies that you should worry about in your donor or in your recipient. But honestly, to start feasibly, because these kits are expensive, to start visibly in any animal clinic, you just need a donor and a recipient. What is the PCV of my donor? I have access to a lab that can give you the PCV of both of them. The first transfusion, even if you don't have access to kits to be able to say if your donor is a DEA1 negative, just ensure that the dog is fully vaccinated, you have screened, there is no blood parasite, and the PCV of your donor is more than 30 or 35%, then you are good to go. I advocate 35%. Anything above 35% for the donor, you are fine. make sure that the weight is more than 30 kg, is in good body condition. The first, if you don't have the kit, you can go ahead and transfuse. Just do your calculations well.
So someone on the chat box was asking, can you shed more light on possible options available if you don't have the facility to carry out screening on hematopoiesis and EMR?
Oh, wow. Honestly, for the donor, you don't want to transmit something that the donor has to the recipient, because the donor, though looking healthy, may even carry more things than the recipient you're trying to protect. So you honestly, you may have some referral labs. You can, even if they are human labs, you could just have, a working relationship with them and tell them that, okay, if I bring this blood sample, all you need is EDTA bottle. If I bring this blood sample, can you just help me screen? Can you just, if they don't know how to check for hemoparasite because it's peculiar to vets, you could just tell them that you don't mind coming to check. They can just help you do your complete blood count, PCV and the rest. We can, as vets, go in there and then, even if it's to ask a colleague to check, okay, please check if there are parasites for me. But we need at least a working lab, maybe by relationship with a human lab.
So there are no shortcuts?
No for blood transfusion, no shortcuts.
No shortcuts. Okay.
Yes, sir.
So someone also was asking, and I think it's an interesting question. Like in humans, where relatives have same blood types, is it also applicable in dogs and cats? Siblings or parents having same blood types with themselves or parents? Can you go through this?
This is very interesting, I must say. Ironically, I did it's one of my studies on blood groups, and I did blood groups amongst some family members, not all, because not all of them were in the same family, and they had different blood types. One had DA negative, the other had DA positive. So it's not like in humans that they are likely to have same blood types. But honestly, as you have mentioned it, this is a place for further study, for me to go further into families to see if there's actually variation or not. But for the little, I'm not sure they were up to 3. But 3 is not enough for a whole number of dogs in Abeokuta. So for the 3 I did, they actually had different blood types, from the same family. But I was told from a literature that I actually read too, that a human can actually, they're looking at whether a human can actually transfuse not the whole blood now, but serum to her cat, his or her cat. So I'm told that in some practices outside the country, maybe that has been, I'm yet to see it done, but I read about it. I hope to do more assignment, more work on that, to see any lab that has done that, to get the human serum and transfuse into his or her cats. But for animals, it depends. We need further studies to be able to really know what's happening within families. But honestly, for today, the blood types in dogs are individualistic.
Okay, someone was asking also, he said, thank you, ma'am, so much for this lecture. Can you please help us go over again the calculations, the anticoagulant blood ratio calculation, ma'am?
Okay.
It was a past history. Can you go back?
Yes. Yes. Okay, so I said, so we have 63 mils of the anticoagulant CPDA in the 450.
So let me cut you, Funke. Going back and forth might not help us. This video or this your topic is warehoused in the YouTube.
Okay.
So that this back and forth will not help us. So back and forth, I'm going to maybe, I don't want to interject. Towards the end, I will talk on the YouTube and 1 or 2 things. So let's, because if we go back and forth, we might not leave here today. And say, you have a program. It's warehoused whole and entire in the YouTube. So we don't have a problem. So they can go there and get the calculations they need. And YouTube is permanent. It's on the Blue Bat TV in the YouTube. Blue space Bat space TV. But anyway, be it as it's made, I'm going to talk on that. Ibokwe is raising his hands, and let's see.
Yes, go ahead, Ikechukwu Ibokwe.
Yeah, sir, unmute yourself, Prof. My beloved senior colleagues. Sorry.
Dr. Ibokwe.
Yeah, Professor Ibokwe.
Oh, Professor Ibokwe, sorry.
Unimed, yes.
Oh, yes.
He graduated in my second year at UNN in 1980.
I know.
By 1883.
Prof, just go ahead, sir.
Okay. What I want to say, I hope you are hearing me very well.
Yes, very well, sir.
Okay, I'm suggesting that Funke should perhaps write a little summary of what the step-by-step procedure, and get it available for those who may want to read as like a guideline.
Okay.
Or you can even get to publish it in Nigerian Vet Journal or your institutional journal as a continuing education. So I think it will be helpful as a referral material for those who want to get involved with the blood transfusion.
Okay, sir.
And in sync with what Professor Ibokwe is saying, the topic is permanently warehoused in the YouTube. I assure you that the last one she had, I think, on ehrlichiosis, canine ehrlichiosis, is stayed there in the YouTube. So I will discuss that towards the end. I don't want to interject.
The major area I want to say a few things is on blood typing. Blood typing requires a lot of reagents that are expensive for us to reach. But the major and minor cross-matching is something that can simply be done. All you need to do is to separate it from the donor. You get the red blood cell out, separate it from the plasma, and wash the red blood cell. Then from the recipient, you get the packed cell volume, separate the red blood cells and the plasma, and then you cross-match. You match the donor's red blood cell with the recipient's plasma, and you cross-match the donor's plasma with the recipient's. So by the time you mix them and you don't have any precipitation, any clotting, you know that you are free to go. Because blood typing is very intricate. Even in dogs, we have minor blood types that are not very well documented. When they are, even when you have got a universal donor and you give that blood to a recipient that is you expect there wouldn't be transfusion reaction, you will still get a transfusion reaction. An example is DAL blood group. If you dogs have it in addition to their regular DEA series, so and when they have this additional blood group typing, it can still cause problems. So, but when you are able to do the cross-matching, minor and major, and there is no reaction, I think it's okay for you to go ahead and do the blood transfusion. But again, the major challenge that is there is for us to be very knowledgeable in examining our blood and know whether an animal is fit for transfusion. That means that your knowledge of hematology should be very good and your basic technique available to you so that you can do full evaluation of your patient. I know even in large animals, we have in goat particularly, we have had animals with PCV as low as 5. And once the etiological factor had been removed, they recovered fully. So it is to be able to be precise about your hematological diagnosis and now pursue treatments in a very strategic way. Transfusion may not always be the case. Transfusion becomes absolutely necessary where there is nothing. There are animals that live on transfusion once a month into their old age, like animals that have deficiencies in clotting, those that have bone marrow problems. You know that these are terminal problems that cannot be treated, medically. So you continue doing transfusion on a regular basis to sustain the animal so long as the owner of the animal wants it that way to sustain the life of the animal and help the owner to maintain the emotional link that he or she has with the pet. Thank you.
Yeah, thank you, Prof. Let me say a very big apology for not recognizing that you were the one. Now, immediately you spoke, I just put the face to the voice. Thank you, Prof, for enlightening us more on the issue of blood transfusion with your experience. But there's something I still like to ask, and I want it's important that we clear it. From what Dr. Adebayo has said and what Prof also contributed now, for me, it's becoming a very intricate process, arduous and all that. How do you think this will be so practicable? I've asked that question before, but it was glossed over. How do you think this will be practicable in a typical Nigerian veterinary clinic? I don't even want to say hospitals because we don't have a lot of hospitals. In a typical Nigerian clinic, and then just oppose it with the cost. We're talking about agents, we're talking about getting a donor, we're talking about so many things. I remember the one we used for the Savannah conference, the reagents we use and the cross-matching material that we use, it cost us an arm and a leg. And I don't think it will be available to just most people like that. So what do we do practically, Dr. Adebayo?
Yes, thank you so much, sir. And I must really appreciate the contribution of my Prof. Professor Ibukwe. Thank you so much. That was profound. If I had to jot some things down, thank you so much, sir. Talking about Dr. Nasser's question, honestly, number one, that's why we have referral hospitals. Because I found out that there are some things that some clinics do that they shouldn't be doing, because blood transfusion is not just done casually. It has to be done under aseptically done under strict, procedures. So if a clinic is not able to do blood transfusion, this clinic can refer. But now talking about the cost, what if, okay, I want to refer a case, but the client is not willing already because of the financial implication? What we can do in that case is there are some times that we can actually have collaborations. Because honestly, if we look at, which I did, the prevalence of anemia in cases in Nigeria, either small animal, large, the prevalence of anemia is so high compared to some other ailments. And this is because, just like Prof said, so many other factors are also playing, as little as nutrition causes iron deficiency anemia, causes anemia in dogs in Nigeria, in other animals in Nigeria. So it's anemia is a whole lot of field that we should look at. Number one, if there is no facility for blood transfusion, just like Prof said, can we look at what is causing the anemia? Can we look at what is causing the blood loss? Can we address it as much as possible? Except it's a life-threatening case that you know that, okay, this is something we can't handle. Because if it's blood parasites, with or without blood transfusion, these animals' PCV, hematocrit, will rise when we are able to identify what is wrong based on a good workup for a diagnosis, and then we treat accordingly, rightfully, and not, leaving any stone unturned. So if we're able to address other situations that are causing this shortage of blood, then we should be able to an extent, take care of these animals. Now, when we have to get to blood transfusion, when it now becomes compulsory, like I have done everything I can, but what is needed is blood transfusion. The first blood transfusion we may wink at, but we should note that a sensitization already took place. We can actually do the manual lab cross-matching procedure that Prof talked about, which is something that I'm also going to write about, just like Prof has, suggested. There's a manual way in which you can get blood sample from both the donor and the recipient, and then you look at how their erythrocytes and their, and their serum, intermingles. It's just looking at the antibodies that are responding or will give, will be prone to antigenic, situations or transfusion reactions in those animals. So the first transfusion we can go ahead to do if it becomes compulsory. As long as your donor, you're satisfied that your donor is in top shape and has satisfied these criteria, this and more that we have listed, you can go on with the first transfusion, but you have to monitor the recipient. So if you have the opportunity, keep the recipient with you for 2 or more days so that you can check what is happening. There are certain transfusion reactions that if we quickly come in, we can save the life of the patient when and if it develops. Thank you, sir.
So there's this question on the chat box. Are there in Nigeria that should not be used as donors?
Well, with my study so far, I've not seen any dog that we should not use. Outside the country, there are some dogs that, have been asked not to be used. But in Nigeria, we have our local dogs, we have our imported dogs. I've used this 2 kind of dogs, and I've not had any problems with them so far, as far as my study has taken me.
So I'm asking those of us on the call now, you have the opportunity to speak, to ask your question. Let me just have your hands raised and we shall recognize you to ask your question or make your comments. But someone's also asked a simple question here. I don't know. Is there a range of time required to transfuse 450 mils of blood to a dog? Team to average time to transfuse the 450 mils of the blood, so to say. Is there a range of time that you have to do the transfusion over?
2 to 4 hours. 2 to 4 hours.
2 to 4 hours.
By the 4th hour, we should be through with collection and transfusion. 2 to 4 hours. By the 4th hour, we should be through with collection and transfusion.
I'm still asking for people to ask questions. I don't want to ask all the questions. I can go ahead and be asking questions, but I want you who have listened there today to at least ask some questions. So what determines the choice of which range, 10 to 20 mils per kg? Do you use, that you use in calculating the volume of blood to be drained from the donor? What actually determines it? Is it like a set range, or is something that was determined before the owner of Samsung will have to talk?
Yes, the 10 to 20 mils or the 10 to 15 mils is actually a standard based on the body volume, based on the blood volume in the body. So with this calculation, I prefer for most range of anything, either medication or anything, you always want to start with the lower range, the reference range of 10 to 15. I prefer to do 10 mils as a rule. So you can still go up to 15, but just ensure that if you're doing up to 15, you make sure that the donor, you take care of the donor, you give hematinics after the transfusion. Some dogs could, if you take too much blood from them, they may collapse. So some of them, you may have to do dextrosaline immediately after you transfuse, if you are taking up to 15 mils per kg. So I do 10 mils per kg, then give hematinics, and then most times actually I do dextrosaline for the donor.
So I'm expecting questions from the floor.
In the chat box, tie your mobile wallet, ask a question, please. Address it.
Okay, in the chat box, I've not seen that.
No, go to chat box.
I'm trying to.
Yes. He said, in a situation where the donor has been sensitized by blood transfusion, first transfusion of blood, that kind of donor might not be safe. This is one of the reasons why cross-matching, both major and minor, is important. Okay, you just passed the comment.
Just a comment.
Just passed.
Yeah, there are other questions I've just seen now. They just came in. I have a question from. Okay, I've seen Tayo Mobile now. Let me see. I'm coming. Some two questions just came in. Yes. Why must donor be above 30 kg? In case where a transfusion needs to be done to a 7 or to 10 kg dog, can adjustment be made to the weight of the donor if a 30 kg plus dog is not available?
No. There's no two way about it. You don't want to take blood from your donor and have the patient collapsing, because the body weight has to do with the blood volume too. So these are calculations that are put in place to safeguard us. You cannot take blood from a 7 kg. That would be suicidal. Please, that would be suicidal.
Then somebody has a very interesting question here. Would there be a way to compromise if there is a cat that needs to be transfused, and what is only available is that of the dog? Has it been done before, reported before, or can it be done? Excuse me, is that not just answer? But go ahead.
I'm glad Professor Mobowale is here too. I've not seen that done, because they don't have the same blood type or blood group. Dogs have dog erythrocyte antigen. Cats have AB and AB. So there's no way you can then take from a dog to a cat, no matter what emergency is before us. We can explore other ways, like having a CPR, provide a cardiopulmonary support, either the localized one, just make sure that there's good ventilation, give hematinics. We can explore other options, but not the dog option into a cat.
Honestly, can you put a cost to blood transfusion in a typical case? Can you put a cost to it? Because I'm still interested in that economic aspect of this lecture.
Okay.
Can you put a cost? Yes.
Yeah. So it depends on what I'm using. So if I'm doing without the kits, the recipient is just coming, and maybe I got the donor for the person already, because we have donors. So without the kit, without anything, we actually charge 20,000. But so now, if I'm using kits, that would be way more than that. That means that if they bring in a donor and I have to do typing of the donor, especially if it's the second time, because just like Professor Mobowale said, the second time is very, you have to do a major and a minor cross-matching, especially when it comes to the second time that recipient is taking blood. So if we are doing major, minor cross-matching, I think the last calculation I did for the kit, major, minor, but we don't have to do the kit, just like Prof said. You can do the normal one in the lab. All you just need are slates, and to just do those ones. Those ones, I don't have an idea of how much that one will cost, but I don't think it will cost up to 5,000 to do cross-matching. The minimal one in the lab. But if you have to do use a kit, cross-matching kit, we may be talking about 20-something thousand just to do a major and a minor cross-matching. Now that's just for cross-matching. So for blood transfusion, generally, we should have minimum with 20,000 naira. We can go somewhere, get the blood bags, get the infusion sets for the blood, and then 20,000 minimum.
Okay, if you say so. There are some interesting questions. They look so simple, but I think we should just have to also look at them. And they're just coming in on the chat box at the moment now. I think you need to really relax and set some records straight. Somebody was asking whether, because of the 30 kg that you are talking about, was asking whether a Lassa capsule cannot be transfused, because a Lassa capsule can never be up to 30 kg. I know our confusion, but then I wanted to put the record straight.
Okay, so is the question, are you asking for the Lassa? Is the Lassa the donor or the recipient?
What is the let me just read it the way she asked it. Does it mean that a Lassa capsule cannot be transfused for a Lassa, with another Lassa, as both are less than 30 kg. You understand?
No. This person is getting this
That's why I
confused.
say you really
You're
need
not
to.
looking at, okay, yeah. You're not looking at breeds now. A Lassa recipient, Lassa Apso recipient can get a dog from a GSD or a Caucasian donor. What we are looking at now is not breed, is the blood type. So what we're saying is that for a donor can be any dog. So it doesn't say that if it's a Lassa, it has to take from a Lassa. No. If it's a Lassa, you can look for a German Shepherd, you can look for a Caucasian, you can look for, as long as you have that dog about 30 kg, then you're fine, 30, 35 actually. If worst case scenario, you don't get 35, don't go less than 30. It's to protect, because you don't want to draw blood from your donor and have your donor collapsing before you and say that person just pitied you and said, okay, use my dog. And you're now having that dog having a crisis. You don't want to do that. So that's why we place emphasis on who is donating and the size of the donor. So a Lassa does not have, Lassa can never be up to 30 kg or 35. So a Lassa can get blood from other big breeds, large breeds of dogs. Yes. Sorry about the confusion.
There's another question interesting, which actually played out in my hospital about 3 or 4 weeks back. We had this dog, very big dog that we needed to transfuse, but those dogs that are available for transfusion as donors are very, very small dogs. So my staff was suggesting that, okay, can we take the dog from each and every one of them and then be giving the dog, separately? And I was just laughing there. I told them to just go sit down. But then, this is the question here now. Thank you, Ma, for the presentation. Is it possible to give blood from different donors to a dog the same day?
No.
That's the scenario that I've just painted. Maybe you have a 40 kg
no, that would be
just about, that are not even up to that. But you have many of them.
Yeah, no. It's just one dog, one donor to one recipient at a time.
See? So, another question. In situations where the recipient dog needs less than 400 ml of blood to be restored, or the donor dog can only donate less than 400 ml, I think people are confusing this volume to increase in PCV and the requirement and all that. Either way, what should happen to the blood bag considering the mils of anticoagulants in the bag? Can it be reduced or discarded based on the anticoagulant or blood ratio? That was why I was asking you to go back the other time, because a lot of questions here, people have confused it. Maybe they want to hear it, even if they saw the slide later.
Okay.
It might just not be comprehensive.
Yes, thank you.
You need to clear that area very well.
Thank you. Yes, thank you so much for that question. Okay, just like I said earlier on, I'll take it slowly now. I said my boss and I, Professor Mobale and I, developed a formula that you have a ratio of 1:7. 1 ml of the anticoagulant to 7 ml of blood. Now, if I need 300 ml, so let me start from the basics. We have a 30 kg donor, 30 kg for easy calculation. So if I am using 10 ml per kg, which is the volume of blood to take from my donor, so 30 ml per kg will mean 30 times 10. That is 300 mils. So I need 300 mils to be retrieved from the donor. With this calculation, what I need to do is that, since I know that in the blood bag, I have a 450 ml blood bag, and in there is 63 mils of anticoagulant. So what I need to do is to know that with the ratio 1:7, this is how I calculate it. So if you are confused about 1:7, just do 400 mils to 63 mils. Then put under 400 mils, 300 mils. So you have 300 mils over 400 mils times 300 mils of the anticoagulant. Whatsoever answer you get here will give you the volume of anticoagulant that you need for the 300 mils of blood. So once you arrive at this, you now take, I don't know, is someone helping me to do that calculation? I don't want to exit this. So what you get here, you now say 63 mils minus your answer in that calculation above. This will tell you how many mils you should withdraw from your blood bag. I think someone calculated it earlier on to be 14 mils. So if that calculation is correct, so that means that 63 minus 14 mils is what you will need as the anticoagulant in your blood bag containing 300 mils of blood. I hope I didn't confuse you again. So I don't know if we got it. Does someone have the answer of 300 over 450 times 63? Okay, let me see if I can quickly do it here. Okay. So that's going to my calculator now.
Yeah.
Somebody has answered it too.
Okay, someone has answered, right?
Is it right?
Aha.
I think
Okay. Has someone answered? So that's 300, I'm calculating myself again, over 450 times 63.
That's 47.25 for anticoagulant.
Yes, so we have 42 mils. So that means that we need 42 mils of anticoagulant for a 300 mils bag. Now,
No,
to know what quantity...
47.25 by one
Okay, is that what you
Abdurrahim
got for?
Abdul Qadir.
No, 300 divided by 450 times 63.
Please.
That's 42. That's 42.
Okay.
So what you do now is that you now say 63 minus 42. That is 21. So you remove 21 mils from your anticoagulant, from your blood bag. That's 21 mils of the anticoagulant is what you are retrieving. Just retrieve it into your needle and syringe and discard that because you don't need that again.
Okay, the other question I'm seeing here is the fact that somebody was asking whether it is economically viable to keep donor dogs in the clinic at any point in time. Considering the incidence of anemia, are you able to justify the fact that dogs must be permanently in the clinic for donor activity?
No, they don't have to be permanently in the clinic. It depends on the clinical operation. What we do here is that we have clients already that we know their blood type because I've done the blood typing of those dogs. So anytime we just run into problem, there's even sometimes that these dog owners will tell you they have their own dogs and they will bring a donor. Now, because it's the first transfusion, and we have the history and everything of the donor, and based on our history, the dog has not been transfused before, then we can still take that because that's the first transfusion. But when a dog is having to do a second transfusion, we have dogs already from it, they stay in their owner's house, but the owners have said, don't worry, anytime. Some of them are breeders. So you can actually have this collaboration with some breeders and then give the breeders something at the end of the day. So just say, okay, you need a dog. I have typed your dog. The breeder's dog is a DA1 negative. So it's a donor anytime, any daytime T. So anytime I need, run into a problem of non-availability of a donor, I just reach out to those breeders and then they bring the dog and then retrieve blood to donate to that particular.
I think, Dr. Deba, I think that's a very nice arrangement that you have just given me now. Because either let's have our own dogs and all that, keep like two in the clinic for emergency's sake. But if you have a working relationship with owners who have agreed to make their dogs or cats available for the clinic anytime, I think that's a very nice one. It's a take home for me.
And breeders too. Breeders.
Yes, and then to Dr. Ibe, please. I've gone through a lot of questions here, and I must tell you that you have to emphasize that people should go to the YouTube channel because the last set of calculation has confused a lot of people, and they are saying confusion now. You understand? So I don't know where this fixation to 30 kg, is coming from. Everybody is fixating on 30 kg and all that.
No, that
So
30 kg is just an example, because it's easier to
that's
calculate
what
with
we are
30.
fixating on. Yeah.
Yeah.
That was why I was
It's just
asking you
an
to go back
example.
and yes, maybe just look at that again and see whether people can, because somebody actually told me confusion,
I will drop it on the chat box now. I'm dropping it
Yeah,
on the chat box now.
fantastic.
Yeah.
So, Dr. Ibe,
Yes.
you really want to emphasize about the fact that they should go and study the presentation and listen very carefully so that they are not here to go ahead and be causing a lot of issues here.
Yeah, yeah. That's
I
it.
cannot see any new questions on the chat box. Is there anyone who wants to make a physical? You want to talk about your experience? We are ready to take your experience, on the issue of blood transfusion. Dr. Ibe has promised that for large animal blood transfusion is going to bring there's going to be another lecture, because I see about 2 questions here on large animal transfusion. And I particularly want to say about equine transfusion in equine programs. That's important because there are also a lot of equine that are really priced in Nigeria. And if they have anemia and all that, how do we just manage the equine anemic patient or equine patient with bleeding disorders? So these are the things that I want us to really look at. And Dr. Ebi too, these are new areas.
Yeah, I said this, that we are moving to the next stage of our VCN will capture our areas of specialties. And in that process, a lot of resource persons will emerge. You can see Savan is on top of the chart because they started long ago. And we can call 1 or 2 people in Savan, like Funke. I don't think if I meet her tomorrow on the street, I'll know she's the one. But other than interactions, based on recommendations, based on where she belongs, in area of practice she belongs, has been on the top of the chart, making a lot of exposure. So, and if we're able to do that in equine, and we're able to do that in large animal ruminants practice, replicate that in aquatic and other sections of our professional diversities and specialties, we'll be able to mop up a lot of resource persons, and we're going to mop up a lot of research scientists, and we're going to mop up a lot of knowledge. I don't believe a veterinary doctor, which we boast, is jack of all trades, master of all. I can say that outside with pomp and candor, but internally I am burning with the zeal and with the real fact and raw fact that we have areas of diversities. And you can see today I kept quiet because I'm almost a non-entity in this area. But if you spark me in poultry medicine, I don't think I will be this. So everybody has his own area. And what I will push based on experience as a former MVMA president and an experience in running our advocacies, at least Animal Diseases Act, it's a proof that I really fought to get that thing on the sign. Those experiences I get, I put them, and I thank the profession for giving me this trust and saying, it's like saying thank you for job well done in your earlier advocacies and then your earlier rehearsed route. What we are going to, I will fight, we're going to bring on board is area of specialties must be regulated, self-regulated. And if other areas are coming up with Savan, and I think Savan should be a reference point, which is judgmental. And if others will come up like Savan, I think we have a practice. And then are regulating to create more jobs. I did that with corporate vets when I was MVMA president. I sat in a meeting with them in Ikeja and then tell them, I'm not going to spend one common MVMA. We don't even have the money. But you have to fund it. But at the end of the day, you make more money. And lo and behold, they have made 1 million times what they have spent in those advocacies. Advocacies are like investment. It's like an input. The output is, you can't know the bound. So if we replicate this, the corporate wealth is a specialty area. If we can replicate this in other sectors, I think we'll have booming practices. From what Funke has said today, we really need some squeezing those in medicine, small animal medicine, in hematology, in cytology, in whatever, in gynecology. I think we should having some area of subspecialties with special orientations and special research. And these are things we should be looking at into third fund, looking at areas or some areas of vital needs. If possible, areas of deficiencies, we can correct it. Everybody all over the world has its own deficiencies, but we can pick up some efficiencies from areas of core efficiencies from some areas in the world I'm fixing here. So people should give us, I'm developing a blueprint as you see me here. I've not been sleeping since, I've been sleeping, I slept a bit yesterday night, agreed. But my mind is working out what blueprint are we going to generate to invade other spaces like oil company, NIMASA, some areas we have not even touched at all. What are, we are not NVMA. What are the circulars we are trying to generate that will make it compulsory that they will be obliged to our certain core area of practices, at least to reduce AMR, and then to reduce infections, and then reduce emerging and re-emerging diseases. Don't worry, I have a lot of things in my head, and I will unfold it as usual as time goes on. So please.
And then, Dr. Ibe, there is this interesting question I want Dr. Adebayo to answer before we probably hand over to you.
Okay.
Because I think something that is a bit, it's going to bring a lot of clarity to some of the things she's been saying. Question 2, the person has asked a question 1, but I want to discountenance at the moment. What will happen if one transfuses blood that was erroneously over-diluted based on the anticoagulant/blood ratio? Say 150 mils collected in a blood bag meant for 450 mils, 63 mils anticoagulant. What transfusion reaction should one expect, please? Dr. Adebayo, are you there?
All right. Yes, sir. So that if erroneously lower blood volume was given, so that's why, I'm so interested in this calculation. I've dropped it on the chat box again to ensure that we actually, because I actually fell victim of this when I started, because it was an area I really took interest in. Not many people were doing that. So I really developed interest. And so when I actually first started, I was just calculating and giving directly. And I noticed that I was losing some dogs, and I was just wondering, what am I doing wrong? I mean, because based on everything else that I should do, I did. I now found out by the time I read more articles that citrate toxicity is a big problem and issue in dogs. So most times when you see those kind of reactions, in fact, you see it most often times you wouldn't have gone far, in the transfusion before you really notice that, okay, something is going on with the patient. So what you want to do is that, number one, you stop infusing immediately. When you see signs of arrhythmia, most times the patient becomes arrhythmic, and then there's hypotension. You just find out that suddenly your dog that was, responding all well, it wasn't that lethargic, now suddenly becomes lethargic, unresponsive, becoming arrhythmic. Then what should be at the back of our mind, that there is actually a transfusion reaction. Maybe this is a citrate toxicity. So like I said, citrate is lethal to animals, so you withdraw immediately. Some have said that the antidote you give is calcium, that is effective in such reactions. Well, I have not tried that. Like I said, when I realized that maybe my mistake was with the calculation, so that is why we now came up with this ratio 1:7 to help monitor the amount of citrate that will be in the blood system of these animals. I've not tried calcium as an antidote, but I really hope it will help. But literature says calcium is a good antidote for citrate toxicity.
So on a lighter note, this 1:7 ratio, have you published it, or is just an agreement between you and Professor Mobowale?
Well, we are in the process of publishing. I got more impetus to write some things today from Professor Ibokwe. So by God's grace, we should have that published soon, sir.
Okay. So I want to hand over to Dr. Ibe. For giving us this opportunity to interrogate Dr. Adebayo. And I'm sure a lot of us here, we have really gotten a lot of knowledge. For me, I've taken one or two things that I'm taking home now, and I'm sure everyone on this call must have also done so. But before Dr. Ibe says anything, please, let us all be ready for the next, how would I put it? Maybe expand our horizon more, and the next step in veterinary medicine. Dr. Ibe has promised that the VCN will be able to help with the subspecialty, and that's the problem in Nigeria. Everybody just does veterinary medicine. We are not very clear-cut everywhere. So one way or the other, we hope that this will help. And I want to thank you, sir, for giving us this opportunity to scratch at this topic, because it's just a scratch. Thank you, sir.
Yeah, and I will plead with those area of specialties that are struggling, those that are strong should have a lean on support syndrome, lean on me, you know what I mean? So, but that is the important thing, that there will be a starting point between with this VCN. I assure you that. I mean, just like we work as a team, I don't think any team will see something good and said we are dropping it. It's going to be, it's going to be a teaser. I recognize the presence of Professor Ike Ibokwe, Medugri, Professor Tayo Mobowale, Professor Olufunke Denubi, and Professor Usman Musa from Othman Danfodio University, Sokoto. Unfortunately, I don't know Professor Olufunke Adenubi. Maybe it's in either FUNAB or in UI or wherever, or maybe it's even in Lauren. Okay, please. Is he a woman, or is he a he or she, before I beat my tongue?
A she.
She. Oh, please, sister, you are welcome. Yeah, you are very welcome. Recognize, probably I'm your senior in the practice. Recognize that those of us who are not recognize that those of us who are not professors, and there are some seniors. We can see Olatunji Nasiri senior to Funke. We are doing Adebayo. You see, what we are doing is across ranks, across gender, across any categorization, private practice, and Funke. And then I'll tell Funke, when you're talking about the economics of your billing, you are in a public sector, and these billings might not support the private sector where we eat from. So whatever be the case, when you're doing your billing, thank you. But that billing might be 10% of what we're supposed to earn, because in the private sector, because a laborer is worthy of his wages. Anyway, that is it. That's all I want to say here. And those in the practice and the clientele, those in the private practice, please, I don't want you to succumb to her prescription on billing, because it might not support us. It might not support our whims and caprices. And then another thing,
it's just for
advice economically.
purposes.
Our advice economically is the the more the elasticity of demand, the lesser your pay. So go to areas of that is inelastic. That what means is the more you build, the response to
Dr. Ibe, maybe you give us the opportunity of presenting a paper on the cost of
yes.
blood in
I know I don't know anything about that too. Please don't take me.
It can be a topic for future.
But on the economic axis, I might prefer some suggestions that might help. But private 20,000 with
no, not private, but maybe teaching hospitals.
Yeah, thank you. Now that's what we want to demarcate.
Basics, for teaching hospitals. If it's private,
it takes me
has to be way more than that.
65,000 to my rickety car. Yes. It takes me 65,000 to fill the tank.
Yes, sir. Yes, sir. Yes, sir.
And then I'll be charging you 20,000. Then how will I make up to add up? And then children are at home. And then your colleague as a wife is in my house. Then if you don't bring this money, you're in trouble. So that's it. Anyway, whatever it is, let's bill ourselves accordingly. I've recognized our big heads here. We are far spent. We are far done. Funke, you have places to go. Let me just tell you the truth. From your manner of presentation, it shows that you're a teacher, you're a researcher, you're a veterinarian. All coherent and mixed and compacted in one.
Thank you so much, sir. Thank you so much.
Plus beauty. Plus beauty. I hope your husband is not jealous. And I like you married a vet, which is, and this one thing I tell them in the university when I go to mentor undergraduates, I say these beautiful classes, girls in your class, don't allow them to go, because we lose them to other areas in this world, engineering, name it, architecture, name it. I won't get hold of them. So let's warehouse them. Let's in-house them and make the best out of them. Usman is laughing. He knows what I can say. So thank you very much, Professor Usman. I will have recognized you. You've been a brother. Thank you for being there in any time I asked you to be there for me as a brother. I have adopted you as a brother, whether you accept senior or junior, I don't care. Important thing is that you are my brother, you're my junior in practice, but you're a professor. Thank you very much. You've been with me, and you've been a dependable brother, honestly. And you've been proving it from time to time. And I am so proud of my profession, that my profession congealed their votes on me and with a trust, because I have done it before. And you can see what I'm reeling out. I will not sleep until I get these things done. That is Charles Ibe for you. Thank you very much, and we love all of you. Andre, say we love you. Adebayo from FNAP, thank you very much. Tayo Omobowale, I don't want to say much about you as a super dependable brother. Yeah. My sister is asking me that music you generated for me. How come? Well, I think we should go and open up a studio and then sing more than Tiwa Savage. And then who again? And maybe, I don't know whether, I think we should bring Samantha Lawode to help us, to give us the sonorous backing. And one to heart in Lagos. We can form a musical group. Thank you very much. At this stage, I think we should call it quits. Thank you very much, Innocent Elect. Nonsa Agenam, Samuel Akawanzaku, David Inusa Dibal.
Yes, sir.
Abdul Karim Duro Simlorum. Well, you're welcome. Oh, that in all the things we do, let us remember that our binding wire is veterinary medicine, and we must promote this profession to the end.
Thank you so much. I appreciate it. I enjoyed the lecture.
Yes. Happy weekend, everybody.
Thank you. Thank you. Thank you.